Mohsen Saadat is Chief of Medicine at San Joaquin General Hospital, and would love to just have you start, if you could, Mohsen, just a brief interview, a brief background on yourself, please.
Sure. Thank you for having me today, San. So my name is Mohsen Saadat. I'm a trained internal medicine doctor, trained actually at San Joaquin General Hospital. We're located in Central Valley, California, kind of underserved and one of the few remaining safety net hospitals in the area. So I did my training here and stayed on as a clinical faculty, mostly in academic community hospital setting, basically. Became the program director, so very involved with the residency program and training, and then the chair of medicine for the past 7-8 years. I also working on clinic sites with our chronic disease management and lead a fantastic team for heart failure, basically clinics and follow-ups from discharges in the hospital. Really, I got a lot more interested in this listening to all the previous guests that you had in how we can collaborate with our technology colleagues to bring the best medicine, especially to the area, underserved and partially underrepresented and short in resources. I think this is going to be the best case scenario. So I'll be glad to chat a little bit from the providers or consumers perspective. Thank you.
That's wonderful. Maybe give everyone a little bit of an idea of the context of San Joaquin General, so that the number of beds, patients per year, some basic demographics, and that sort of thing.
Oh, sure. So it's about the 200-bed hospitals. It's the only trauma center in here. As I mentioned, it's a community and teaching academic facility. We do have a lot of subspecialty and primary care clinic affiliated sitting in our own campus. And again, mostly dealing with underserved Medicare population, but definitely big in academic and teaching as well.
Wonderful. And in your experience, Mohsen, what are some of the reasons for slow implementation of AI right now that you're seeing in clinical medicine, even though we're seeing hospitals, especially for things like AI and transcription, using it now at a rate of about 50%, even in the last 2 years. And for the 50% that aren't using it yet, 30% of that is actually, of those folks are adopting it or in the midst of implementing it. What are some of the reasons for slow implementation of AI in clinical medicine?
Yeah, it's funny that we think it's a slow, but I really think it's a comparison, right? The rate of growth and excitement that's all around AI in the last couple of years really is unmatched, and we just need time to catch up, I think, with some of that technology. But I can touch up some of the points. I think anytime that you come up with a new technology, it's often there's a lot of excitement around it, and it kind of lead to a little bit of an unfocused, experimentation across different application. By that I mean, when you look at the structural framework, for example, for evaluation on some of these AIs that have been implemented, really there's not that much good data. If you look at, I think I was looking at the JAMA articles in January 25. That shows basically studying on evaluation of efforts made on LLM in clinical setting. And strikingly, only 5% of the data was really real patient data out there. There was finding a kind of fragmentation and in mirroring basically the actual clinical use. So these are the issues that I think important for clinicians, for us to be able to adapt this. Another thing is lack of basically guide rails. We are so used in medicine with the standardized performance metric, and I don't think we have a actual structure on this still. Lack of skills in using and keeping up with the data, I think that's another huge thing, and that's really on us. But again, the speed that it's moving makes it a little more difficult to catch up. Disparities in usage. You mentioned that there's a lot of big university centers that are using it, but still there's a lot of smaller areas that has a high concentration of patients that they haven't been tested on yet in that area. I mean, these are all the areas that I think we can improve on and catch up. But I think those are some of the reasons for slowing down. Another big one, I think, the lack of detailed cost analysis. For us, that's very important. And smaller healthcare system, I think cost analysis becomes very important. And except in the area of radiology, really, we don't have that much good data that we can go with. There's a promise of $200 to $300 billion saving globally with bringing Gen AI, but I don't know if that's also counting on the cost of implementation, cost of training, cost of monitoring, cost of maintaining all of these or not. So I think those are 4 or 5 areas that kind of make us put the brake on it a little bit.
That's fantastic. And talk a little bit about agentic AI, right? Our audience here today, again, global audience, also very much high executives from hospitals, clinics, pharmacies, certainly health plans and health systems and life science companies, pharmaceutical, med device, as well as government executives and researchers and startups and investors. Tell us a little bit more about, they've got various levels of understanding of AI, from rudimentary and what they read in the press to detailed, and they're creating some of the most advanced AI in healthcare today and life sciences. Maybe you could discuss a little bit about agentic AI and what you see as, number one, after you define it for everybody, where do you see the opportunities for it to help patients and physicians? And where do you see the challenges in terms of its implementation and whose cloud does it sit on and things like that?
Right. So this is very interesting. I think the agents in AI in general have become one of the hottest topic right now. And in healthcare, and I think the easiest way for me to, if my understanding is correct, and to explain it to my residents and my faculty, is that instead of having basically separate AI tools for different tasks, you basically have one AI agent to control all of them. I think that's a simple way that I'm thinking about it. Now, you can have multiple AI agents. Patients can have an AI agent. I can have an AI agent, some specialists can have an AI agent, but that's the whole idea, to basically pull all of these data together and have an agent presented. So, but I think it's important to note, so that's a fundamental shift actually from using AI as a sophisticated calculator, the way we used to think about it, to now deploying it as an agent. I think going from something that was very passive and reactive, but you were used to, and we set up all of our basically metric and evaluating tools on, to now going to something that can take initiatives and actually can propose solutions. So to me, the use case is amazing. You fall in love with the use case actually, but again, the technology is what has to keep up. What we're talking about is basically potentially navigating the whole EHR, complex EHR system, and bring in and piece together all of these fragmented data and actually present it to myself as a clinician, to allow for our subspecialists to talk to each other at that level, bring all of these histories and interaction together. So it sounds wonderful. Now, the challenges that I see in some of this stuff happening is really, again, goes back to what kind of sensitive information we might basically entrust AI models with. And I think that's a huge discussion to have. Again, we need some framework on evaluating and regulating, and basically you find the proper use and usability on it in the actual clinical setting. Because remember, now it's not anymore a passive tool. It's something that needs to be evaluated at a much different level that our current evaluating methods allows for. The performance of these AI agents obviously needs continuous monitoring in different settings, because basically you're constantly looking at the safety and accuracy of the data. What are the appropriate cases? I would like to look at it as it has come out as a clinical teammates. I mean, that's how helpful they can be. But when I look at it as a clinical teammate, I look at, let's say in academia, when I have an intern that rounds with me, so that intern's very good at collecting all the data, put the relevant information together, come up with a little summary and present it. But he or she had gone through a lot of training to get to that level to be an intern. I, as a clinical instructor, have gone through some training to know how to interpret that data the interns gave me. Which part of those now I have to go back and get my own history? Where do I have to go back and do my own physical exam and come up with it? So truly, I'm looking at it as a healthcare teammate. But again, a lot of training has to go to this. Bottom line, I think it needs, basically, we need as clinician compelling evidence to show that these agents are actually enhancing the accuracy, safety, and productivity for our patients.
That's fantastic. Any concluding notes before we wrap up the session about any recommendations or advice you'd give to the folks that are watching from around the world?
No, I think there are a lot of low-hanging fruits that we're already using, in medicine. A lot of it, AI Scribe, of course, is one of the big ones that we're using, the ambient listening device. But to me, I think I am much more interested on working with our tech partners and investors on actually trying to guide, bring the safest thing to the patient. To me, AI is not just about innovation. It's really about improving health, about saving life, about improving equity, and also hopefully reducing costs. So we're excited to get started on it, because the only way you can get ahead on anything is to get started. So looking forward to working and bringing the best medicine to everyone.
I love that mantra. The only way to get ahead is to get started. The only way to move forward is to get started. That's really good, Mohsen. Thank you very much for joining us today.
You're very welcome. Thank you so much.